Yeah, so this talk, I mean, the title is in fact quite asking the question, is the final piece in the jigsaw actually to transplant an HIV positive kidney into an HIV negative recipient? Okay, and I think that's the final question in a process that's happened over the last 3 years, centered largely around what we've been doing in Cape Town. But to get to that point, I'm going to explain to you a little bit initially about the problem, a little bit about the ethics and what went on actually during the program, because I think it's interesting on an ethical basis, and then go towards this final question of, could we foresee a day where we actually give somebody HIV, give somebody a kidney, or for that matter, other transplants, stem cells or whatever, that have from an HIV donor. And straight up, I think I really need to acknowledge this person who is Dr. Elmi Muller, who's the transplant surgeon at Groote Schuur. And Elmi really single-handedly has led this project with a team supporting her, but all that the positions we've got to so far, really in South Africa, is down to Elmi's drive. And as I'll show you, she's been through quite a lot to drag us all through to this point. And I really want to acknowledge her straight up for all her work. So as I said, we're going to look at the clinical problem. We're going to look at what happens when you have this issue that you need to give people renal replacement therapy, RRT, with diminishing resources, and this problem area with such a high HIV burden, ethical issues, and then this final issue about HIV positive to negative. It's not just South Africa, of course, on the continent that has a problem with kidney disease. I mean, this study from Kenya, which excluded patients who would have kidney disease from the other main causes, they looked at how many of their HIV patients who are heart naive had renal insufficiency, and about a quarter of them had creatinine clearance of less than 90, and severe renal insufficiency was in 2% of their HIV patients. And at GF Jooste Hospital in Cape Town, Graham Menkes and his colleagues looked at their clinic population, and although the median creatinine clearance in males and females was good, it was over 100. In fact, again, about 3.7, around 4% of patients had creatinine clearances of less than 50. And these are people just presenting to the clinic with HIV who are ART naive. So you may say, well, 4% is a low percentage, but in fact, of course, with the numbers that we're talking about with HIV, that's a considerable number of patients. So in terms of etiology, what drives and causes the HIV, the kidney disease in HIV, and the categories, well, there's a number of different problems that one sees not only in HIV, the acute renal failure, sepsis, etc., TTP. Then there's the tenofovir issue in terms of kidney disease, and then there are unrelated comorbidities such as diabetes and hypertension. But the main driver we feel, certainly in the African population, is HIV-associated nephropathy. And to a lesser extent, there's a contribution from an immune complex disease, which I'm not really going to talk about further, called HIVAN. So characteristically, HIVAN gives heavy proteinuria. We tend not to see that much edema or hypertension, but it can progress to end-stage renal disease in months. And in fact, it can even do it quicker. There's a case report that was in the New England Journal, which I'll allude to again later, from '97, which really showed progressive renal dysfunction, renal failure in somebody who was seroconverting. And in fact, it was a HIVAN-like picture when they did the biopsy. So it can progress very rapidly from the onset of HIV, but more commonly we see it later on in HIV disease. And it has a characteristic histopathology. And if you look at that, I mean, this is a normal glomerulus, and the characteristic is a focal sclerosis, but it's a collapsing variant, so the glomerulus kind of collapses in. So it's easy to see on biopsy. And it's not only the glomerulus, of course, that's affected, it's also the renal tubules. And again, this is a normal picture. And here one sees marked fibrosis in the interstitium. There's this sort of cystic degeneration and dilated tubes. So HIVAN, the associated nephropathy, gives a characteristic appearance histologically. Now, what actually causes HIVAN? And firstly, it's probably multifactorial, and secondly, it's not completely understood. So we know that there's a genetic element. So there's this non-muscle myosin gene, MYH9, that has been associated and is expressed in podocytes in the kidney, and a particular haplotype in African Americans has been shown to be overrepresented. So there is some genetic basis. Then there's the renin-aldosterone-angiotensin system, which is activated and also plays a role in driving the histopathological and clinical changes we see, and particularly the angiotensin II is the key factor there. And then there's the issue of direct infection of HIV-1. Now, the cells that HIV actually infects in the kidney are the podocytes and tubular cells, neither of which have CD4, CXCR4, or CCR5. An entry of HIV-1 is thought to be not related, obviously, to the CD4, but is thought to be related to lipid rafts. So on cell membranes, there's cholesterol and glycosphingolipids, and many viruses, not only HIV, can use these to actually internalize through endocytosis. And also there's an endocytic receptor, C-type lectin, called DEC205 in the tubular cells, which are involved in pulling the HIV into the cell. There's been a lot of work in transgenic mice and in vitro to show that a variety of the different HIV gene products and proteins can have a detrimental effect on kidney cells, both on the podocytes in the glomerulus and the tubular epithelium. And indeed, VPR, for example, on its own can actually enter cells, VPR being secreted from HIV-infected other cells, and can be taken up by kidney cells and cause damage itself. So it's not fully worked out, but we think there's direct infection, there's this renin system, and there's a genetic component. So how much of a problem is it in South Africa? Well, there have been a few studies. Here in Johannesburg, 104 biopsies, just over a quarter had HIVAN. In Cape Town, in an earlier study, and there's about to be publication of a much larger biopsy cohort. In Cape Town, we saw in that earlier study of biopsies in HIV-infected patients with proteinuria, we saw 50%, so a higher rate. And this cross-sectional study in Durban, they were looking for proteinuria and microalbuminuria. 38 of 615 patients that were screened had proteinuria or microalbuminuria. 30 were biopsied, and 83% had HIVAN. So we know that HIVAN is driving the main pathology in the kidney in HIV in South Africa. And you don't even need a biopsy. If you have proteinuria, that's enough to ring the alarm bells. And this study from 2004 in a cohort of 2,000 women looking at risk of death or new AIDS-defining illness was greater in the naive women who had proteinuria or an increased creatinine over those who had normal function. So even in people who just have proteinuria or microalbuminuria is a cause for starting early antiretroviral therapy. And what about antiretroviral therapy in HIVAN? Well, there haven't been very good studies. There have been small studies to date. There is a study going on at the moment looking at the role of antiretrovirals and steroids. But the studies that have been published are relatively small, and were from earlier days in the mid to late 90s. So in this study, 23% of the patients who had HIVAN were on AZT, and those that complied didn't progress, but those that didn't comply, their renal function deteriorated. So there was a clue that AZT was playing a role. And then there were a couple of studies which were mainly looking at the ACE inhibitors to inhibit that renin-angiotensin system, but also they were also some of them on antiretrovirals. And again, antiretrovirals seem to be beneficial in delaying end-stage renal disease. So there is a role, certainly, for antiretroviral therapy. And in the era of antiretroviral therapy, we have seen a reduction in presentation of HIVAN overall, but it is still an issue. And that's what I want to come on to now. So that was really a basic introduction of the problem, the clinical problem. But what do you do when you're faced with patients with HIV who are already on antiretroviral therapy, are doing relatively well, but their renal disease was progressing. And that's where we were in 2007, 2008, when, as Francois said, we started discussing this issue. And this is the problem we were faced with. And these are 4 patients that became, in fact, the first 4 renal transplant positive to positives that I'll come on to. So these were HIV patients who, most of them had advanced disease. They were on antiretroviral therapy, and their viral loads were all undetectable, and their CD4 counts weren't bad. Creatinines, however, were bad, up to 1,700, and their renal biopsies tended to show HIVAN in the main. One had hypertensive nephropathy. And they were unable to access dialysis, mainly because they were rejected, and because they were rejected in the state system, they also didn't have insurance. So here we were with this set of people who needed something doing but couldn't get onto dialysis. So this is when we started discussing the issue of could transplantation actually be the answer. So at that stage, and even now as well, there was this algorithm for what you did with patients who were presenting with end-stage renal failure. And what would happen is that there would be a number of contraindications to getting onto hemodialysis or peritoneal dialysis. Now, you need to also keep in mind that you would only get onto hemodialysis or peritoneal dialysis outside of the very acute dialysis that you might do for just a very sick patient who might need 1 or 2 episodes of dialysis just for them to recover. I'm talking about people who need dialysis. They would only get on if they were transplantable. So you have to have criteria to decide who can be transplantable. And so those that were contraindicated or were denied from the program were patients who are older than 55, those that had poor compliance issues previously, poor social candidates for many reasons, and were generally thought to be a poor transplant candidate, but also a poor medical candidate. And in 2000, 2007, 2008, that included anyone who had HIV. So faced with this problem, we were looking for evidence that actually HIV patients might do quite well from a transplant. And we looked to the United States, where there was already a program and studies being done, and this from Michelle Rowland and Peter Stock's group in the early stage, looking at 1 and 3 year survivals in the red of kidney transplant patients. And these were HIV positive patients who were given a negative kidney. And what we saw was actually the transplant patient survival to 3 years, 94%, and the graft survival was really pretty good. Okay? So HIV patients that got HIV-negative kidneys did well, which was a good thing and helped to make some of the arguments going forward. And these studies in America have increased, and there's been a much larger multi-center study from throughout the United States, which has been reported on recently in the New England Journal last year. And these graphs were prior to the publication. And really, they looked at 150 renal transplants, again, HIV-positive patients who got a negative donor organ. And the red line is the general, how people do generally on the renal transplant program. These are all comers. And the blue line is HIV-negative patients who are over 65, so they're a bit higher risk. So the red and the blue lines are the HIV-negative patients in the general transplant registry, and the broken black line is how the HIV patients did. And you can see that they actually did better than the slightly higher risk normal patients, HIV-negative patients, sorry, and not too much worse than the general population. So again, this is actually very encouraging and suggests that HIV-positive patients in general do well from getting a kidney. Now you might say, well, okay, we might not need to transplant the patient. Why don't we just give them dialysis? Well, there were studies looking at how patients did immunologically and virologically who had dialysis or transplant. This study from Philadelphia took 2 groups, one who went on to dialysis and one who went on to were transplanted. And the CD4 count you can see in the block line here, and the transplant group increased to a much greater extent, significant extent, than those in the dialysis group. So patients that are dialyzed generally don't tend to increase their CD4 count very well, whereas those on the transplant who are transplanted do. And in terms of survival, those that had transplant, the survival 5 years was significantly better than those that were on dialysis. So we also know that generally patients that are transplanted do better than on dialysis. And of course, it's not just how they do, but it's the quality of life that you can give somebody. I mean, remember that patients who go on hemodialysis, they have to come in 3 times a week or so. It's very difficult to hold down jobs. It's, you know, it's a real difficult practice. And so transplant does allow patients to live, you know, perhaps a freer life. However, the problem, of course, is certainly in South Africa, is that demand outstrips supply. So from the US, the stats indicated that about between 3 and 12% of patients with HIV will get HIVAN. Now, if you sort of simplify the maths and say we have 5.5 million people in South Africa with HIV, and 550,000 of those will develop HIVAN. So even if 10% get end-stage renal disease, that would be 55 patients requiring dialysis. Even if it was 3%, it would be 15,000 patients. And the current dialysis population, total population in South Africa is 4,500. So there's potentially a massive burden of end-stage renal disease that's coming our way, and we have very few slots to dialyze people. So what are the factors that would support using an HIV-infected kidney? Because up until this time, HIV-infected potential donors, the kidneys were being discarded. They weren't being used. So what are the factors that might make us want to use these HIV-positive kidneys? And I've told you some of them already. And the other issue about it is that in the brain-dead donor population has obviously mirrored the rise of HIV in the general population. So really, depending on which province you're in, about 15 to 30% at worst of donors are HIV positive. And if those are all being discarded, they're not being used. And if they're not being discarded, you've got a potential pool, an increase in the pool. So it opens up a new pool, and it would also, of course, reduce the potential impact on the HIV-negative dialysis population that needed a kidney. Because if you suddenly have 55,000 potential people who would HIV positive who also require a kidney, they're going to be competing. So the challenge was that you had this imbalance. You had this problem with an increasing number of brain-dead donors being HIV that were being discarded, and an increasing demand from HIVAN for the kidneys. So the question came, why not use HIV-infected donor kidneys? Now, when we started discussing this, the main issue that people were concerned about was, well, is it really ethical? Is it right to give an HIV patient another HIV strain knowingly? And the main concern, of course, was that there had been cases in the literature of superinfection with another HIV strain actually causing a progression and worsening of the HIV disease. And so there was a big question mark about whether giving somebody HIV via the kidney would actually do harm. Now, with antiretroviral therapy and judicious use of the different potential drugs, we felt that you could actually suppress the incoming virus. So you could control potentially viral replication. And so we felt that this wasn't an absolute contraindication to doing a transplant. So the other ethical questions that there was, okay, is this actually research? You know, you're doing something really novel. This is experimental. We don't know what's going to happen. Or is it actually clinical practice and just a novel procedure? Does it actually equate, for example, to using a drug in an off-label manner? And does it need to go through a human ethics committee at all? So what actually happened? Well, what happened was the transplant surgeon discussed the potential to do the procedure with the human research ethics committee and the head of it. She was advised that to do this transplant, it's actually a clinical decision, unless it's in the context of a study, and then the ethics committee would have to be involved, and one would have to go through the rigor of the study. But if you're not doing it in the realms of a study, then it was a clinical decision. And in fact, the non-heart-beating donor program in 2007 at Groote Schuur had been started in relatively the same way. It didn't go through ethics committee, it wasn't felt necessary by the committee, and it was a clinical decision to use marginal kidneys for high-risk patients. So in September 2008, we did the first HIV positive to HIV positive transplants. So kidneys from a person who had been in a road traffic accident, who didn't know their HIV status. In fact, the HIV status was found during the workup for the donation, was used for 2 patients who got these kidneys. The patients who were transplanted were actually doing pretty well. And we published this 1 year after those 4 transplants. And our results basically were the most important thing, firstly, was these patients were not on dialysis. They were doing well. The viral loads were all undetectable at 6 and 12 months. Their CD4 counts, remember, they're on immunosuppression as well. They're on tacrolimus and other things. Their creatinines were good, and their renal biopsies looked promising. All of them got ATG, antithymocyte globulin, to prevent acute rejection. One of the things from the American studies was a higher rate of acute rejection of the kidney in their population. They didn't use ATG. We use ATG up front. They're all immunosuppressed with tacrolimus, prednisolone, and MMF. And in terms of opportunistic infections and malignancies after the transplant, which is always a concern, in the NIH study there were relatively few, with a much larger number of patients obviously than we have been seeing. And in our group there was only one, a schistosoma mansoni, in one patient who had had it previously, and it recurred. So we haven't seen to date any serious opportunistic infections or malignancies in our transplant population. So all the patients get tacrolimus, and tacrolimus and antiretrovirals interact. So if you're on nevirapine or efavirenz, which are inducers, the tacrolimus levels are reduced so much that you have to use massive doses of tacrolimus. Whereas if you're on a PI, a boosted PI, the ritonavir causes an increase in the tacrolimus levels, and you actually have to use incredibly small amounts. Now that's important because tacrolimus is extremely expensive. So paradoxically, it's much cheaper to transplant an HIV positive patient than it is an HIV negative patient. And I mean, the whole interaction previously, we used to use ketoconazole actually to do the same thing as ritonavir. But if you look, these are again figures from ELMI, slightly small, I'm sorry, but in an HIV negative patient, the cost is around, I think it's 110,000. It's basically 10 times the amount an HIV positive patient costs to transplant. So again, there's actually a cost saving, so it makes health economic sense. So what are the ongoing issues with the transplant program was, well, will this HIV-infected kidney act as a Trojan horse, not only for HIV, but for other pathogens? The whole question about resource allocation, what do you allocate your resources to is always a discussion, particularly when you're dealing with the so-called Cinderella parts of medicine, where transplant is often seen as something which is very high-tech and affecting only a small number of the population, whereas you could do better, with the same money, you could do more for more people. One can argue that. And then still the question mark about long-term outcomes. Will the patients that are transplanted get HIVAN again? Will they fail virologically? What will the effect of the incoming strain of HIV be? These are all unanswered questions, but questions that we're trying to look at with the research program that we're building up. So currently, the Research Ethics Committee finally approved the study, but the Western Cape Provincial Administration initially restricted the transplants to private patients. Now that too is ethically interesting, because private patients were able to access state kidneys, as it were, but of course state patients weren't able to access either state kidneys or private kidneys. So for a time, and that's now stopped, this restriction to private patients I think was actually almost unethical. But it's now been lifted, and we can transplant. We have done one transplant of a state sector patient. And there's been 11 transplants to date. The one death was completely unrelated and occurred relatively early on. But the other 10 are doing well. They're doing very well. All of them have undetectable viral loads. Their CD4 counts are okay. Some of them are even extremely high, and their grafts are functioning well. And I'm glad to say that the transplant surgeon is very much alive and kicking, and on Saturday was awarded Woman of the Year for Health by the ShopRite Checkers. And there she is with the other winners. So, what about the slightly wider challenge of renal transplantation? And this is now coming towards this issue about equity for HIV-negative patients, which, having spent all our years saying how HIV patients are being discriminated against, we're now sort of starting to perhaps question the other side of the coin. Well, let's have a look at it. So the wider issue is that about 500 per million of population will develop end-stage renal failure if you look generally. And if there's a 50 million population, so that's 25,000 new cases. Now, the brain-dead donation rates are low because of the refusal from the families, and the cost of dialysis is very high. Now, each province and maybe different institutions have their own way of deciding who is an eligible candidate for dialysis and a transplant. And in the Western Cape, this is the tool that's used. So there's a meeting every week, and patients are presented by the nephrologists to a team, multidisciplinary team, which includes nephrologists, transplant surgeons, social workers, lay practitioners, and other lay people, and sometimes other specialists. And the patient's case is presented, and they are categorized into 3 different categories. So if they're category 3, any one of these would exclude the patient. So if the patient's over the age of 60, if they're morbidly obese, for example, if they're hepatitis E antigen positive or have cirrhosis, so if they have active hepatitis B, interestingly, if they're a non-South African citizen. But there are others, an advanced disease, and these patients, their dialysis is denied. Category 2 are patients who, if there is a dialysis slot available, they will get it. And to be category 2, you have to be slightly younger, of course, under 60. You have to, these are all criteria which would put you into category 2. And at the moment, and hopefully that's going to change soon, HIV patients are in category 2. Now, to get onto a renal replacement program, to get onto dialysis or be accepted potentially for transplant, you have to have been on antiretroviral therapy, adhering for 6 months. You have to have a CD4 count of over 200, and you have to have an undetectable viral load. And if you fulfill that criteria, you are at least in category 2. We're pushing. At the moment, this still stands, but I think there is a move to push against this and to put these patients into category 2. If there isn't a slot available, you're sent home. And most people, of course, with the very end-stage renal disease will die rapidly. If you are in category 1, so if you have none of these, but you're under 50, your body mass index is okay, you're HIV negative, that says we're going to change, and these other things, you will receive dialysis. And if there isn't a slot in the state sector, you will be put into a private dialysis slot, and so you will get onto dialysis. But it's this category, this group particularly, this one in the middle, that if there isn't a slot available, then they'll be sent home to die, whether they're HIV positive or HIV negative. So the current situation is mandated that an HIV negative patient who's category 1 will get a dialysis slot. We're working on this for the HIV positives. And the category 2 patients, if a space is available, if space allows, you'll get one. But again, in terms of actually transplantation, at present, if there's an HIV negative donor organ, then if you're HIV positive, you'll get it. And And if the donor organ's positive, you could still get it. But HIV-negative patients can only get a negative donor organ. Nobody has transplanted an HIV-positive kidney into an HIV-negative person as yet. So the final piece of the jigsaw, should in fact HIV-negative patients be offered donor kidneys from an HIV-positive donor? Is it unethical indeed to withhold potentially an HIV-negative kidney to an HIV-positive kidney to an HIV-negative recipient if HIV-positive people can get both? Again, this is turning it on its head now and saying, are we actually discriminating now against HIV-negative patients? Should there be one pool for all cadaveric donors, kidneys? Now, this study from Johannesburg with Francois and others, June Fabian, were involved in looking at attitudes in really 4 groups: patients who had HIV in the renal clinic, transplant clinic, and people who didn't have HIV groups. And it was basically those that had HIV positive. It was pretty well accepted that they should get an HIV positive kidney, both with the patients and the healthcare workers. But in the group of HIV negative patients that were polled, a minority would accept an HIV positive kidney if offered one. Now I don't know the exact numbers because they weren't actually given, but a minority, obviously a small number of patients who were negative, it would be okay. They would agree to have an HIV positive kidney if given one. Question about doing no harm. Is it acceptable to knowingly infect someone with HIV? Of course, in most circumstances, we would say, no, you cannot. But if you're dealing with somebody who's being sent home to die, or potentially say, well, if a HIV positive transplant came up, would you take it? Death, transplant, that's the question. It's not unprecedented either. We give people CMV when we transplant. Okay, you might say, well, CMV is not as high mortality, it doesn't have the same connotations. Well, mortality from CMV actually is appreciable in the transplant population. Morbidity certainly is. So it's not unprecedented that we knowingly give people viruses. And what about the role of post-exposure prophylaxis and antiretrovirals in general if you were going to give somebody an HIV-positive kidney? Well, we know that you can prevent in occupational exposures patients, and in these animal studies, from actually getting HIV if you have a risk injury. So in this study, macaques were all infected with the SIV, the HIV equivalent in the macaques. They were given tenofovir before or up to 24 hours after and continued for 28 days, and none of them got the SIV, so they were all protected. Similarly, in HIV exposure, post-sexual exposure in the animal studies, if you gave antiretrovirals within 72 hours, if you gave it within 12 to 36 hours, they were fully protected, and even at 72 hours, half of them were protected. So we know potentially antiretrovirals can work, and of course we know particularly in PMT-CT. Furthermore, is it actually acceptable when we're thinking about this, we have this ability to control virus with antiretrovirals? And then there's the argument about unseen added costs to the health system of actually giving somebody HIV, and then potentially there are other health costs from the HIV disease in the long term. Does giving somebody an HIV-negative patient an HIV-positive kidney, does it fit in with ethical principles? Well, I mean, these are the sort of pillars of ethics that everybody always quotes. So autonomy, the self-rule of the patient. Well, none of this is ever going to happen without, obviously, full counselling, informed consent, etc. You know, you have these issues are very complex, but they have to be discussed fully, and the patient maybe should have self-rule to decide. Non-maleficence, doing no harm, well, there's the question mark about that one, of course. That is the main question, I guess. Doing good, death, transplant. Justice, access to healthcare and fair rights. We fight for HIV patients' rights. I know this is stretching the point, okay, and you might say, well, this is really, you know, we shouldn't even be discussing this. But actually, I think we should be discussing this. It's not only in HIV transplant. I mentioned other renal transplants in other settings. So what about the stem cell transplant recipient whose sister is HIV positive and she's the only match? Do you allow it? In other settings, there are going to be these questions. And interestingly, I gave this talk in the United States, in Los Angeles. I was visiting a hospital there, and I gave this talk about a transplant program, and we put this question forward. And it was absolutely, there was no question about it. Unanimously in the room, there wasn't one person that said that they wouldn't support giving an HIV-positive kidney to an HIV-negative patient if they needed it. And really, it's because in the United States, the perception is completely different. In that clinic, there was no issue about the patients being on antiretrovirals. They were all on antiretrovirals. They were all doing well. They all had viral loads undetectable. The issues were much more about where their facelift was going to come from, who was going to do it. This was in Los Angeles, so you can imagine that's why. But I mean, it was accepted that HIV is a chronic disease that can be controlled. And we're not there yet, obviously, and we're behind. We're getting there. And we're thinking about quality of life in a broader aspect. When you're, again, thinking about transplant, dialysis, there's this quality of life issue. So I think what I've tried to do is give you the clinical context that we're facing. This issue that in HIV, renal disease is a very real problem in morbidity and in mortality because of the progression to end-stage renal disease. There's a heavy burden of those patients who, if we had the resources, we would be giving dialysis to and thinking about transplantation, but we don't have the resources. And so there's a question mark about who should get. And up until 2008, HIV patients were being discriminated against and were not getting even onto dialysis programs. Now that's changed with everything that's happened through the Clinician Society, through Elmi's work at Groote Schuur. And now we're in a different position. We've looked at some of the ethical problems that we faced going through those first transplants, and that was interesting, an interesting time, rocky time in itself. And this is now sorted out, and everybody's on the same page, and everybody's going forward with this. And then there's the question about whether we could actually see a time, and whether it's ethical to give somebody who's HIV negative HIV. Because that's what we're going to be doing. We can discuss whether or not it's likely that donor kidney bringing the HIV in is actually going to cause a seroconversion and long-term HIV in that patient. That's even an interesting discussion, and potentially we can touch on that. But I think these are questions that we need to start talking much more openly about. And I think they challenge us as HIV treaters, but actually more in general as healthcare providers to not only HIV patients, but non-HIV patients as well. I want to again acknowledge Elmi, who's really driven this. Del Khan is a professor of surgery who's involved. Zunaid, the main nephrologist. Profs Charles Swanepoel and Brian Rayner are also in the department, have been involved. Some of the transplant nurses, Fiona and Heather, and really the help we've had from San Francisco, from Peter Stock, and the HIV side from Michelle Rowland. Thanks very much.